Welcome, everyone. We're going to go ahead and start. I suspect we're going to have uh, more people over the next few minutes, but to make sure that we have plenty of time to discussion, I think we should go ahead and begin. I'm David McConkey. I'm the director of the Johns Hopkins Greenberg Bladder Cancer Institute, and it's my pleasure today to welcome you to our fall educational Grand Round series. We're delighted to be kicking it off today with one of our rising stars, Max Cates. Max, as you can see, is an assistant professor in the Brady Urological Institute, and his clinical focus is on bladder cancer. Within our program, he is leading efforts to develop novel approaches for intravesical therapy, and he is a product of Hopkins. He was trained here and rose through the ranks to become an assistant professor over a year ago and completed a fellowship here as well. I'd also just like to raise your attention, your awareness of the upcoming Bladder Cancer Advocacy Network virtual walk, which will be held first weekend in October. More from us on that as we get closer to that date. I encourage you all to go to the Beacon website and sign up to join us for that walk. And again, it's my pleasure to turn it over to Max, who will give you an update on alternatives and options for patients with BCG in short supply. Max?
Thanks so much, David. You know, it's so fun to see the list of participants. I see, you know, several of my patients and several others who I've known through the years, and this should be fun. You know, unfortunately, through Zoom, we're not in a space in which you can interrupt me very easily, although some of you who are technically savvy may be able to do that. But I want you to interrupt through the Q&A as much as possible. David, if there's something that comes up that is like a pressing question that's topical, it won't bother me at all to stop in the middle and answer it. Otherwise, we can wait till the end and then kind of have as much of a free-for-all as we can sort of do in this format. So let's jump right in. I do have one disclosure that I'll be discussing research related to a patent that I have. I have not made any money on this, and it is not in clinical trials. So it is, but nevertheless, it is a disclosure. So let's just talk about bladder cancer staging in general. A lot of you are maybe savvy patient advocates or patients yourselves, but really what we're going to be focusing on today and focusing on for this talk, and maybe we'll talk more about muscle invasive disease and metastatic disease sort of in the Q&A, but we're really going to be focusing on this group of patients that has non-muscle invasive bladder cancer. So I describe that essentially to my newly diagnosed patients as a bladder tumor is like a piece of broccoli. Okay, there's a floret and there's a stem, and then there are these roots. We don't often care about, as a urologist treating these patients, I don't often care about the floret, the size of the frond. And the stem doesn't matter so much, but it's these roots that get into the dirt, get into the bladder, and how they invade, how deep do they invade? That's what defines how we're going to treat our patients. So this is the old paradigm. If you were a patient treated even 5 or 10 years ago, this is pretty much how it went. If you had non-muscle invasive, and I apologize for the acronyms, if you had NMIBC or non-muscle invasive bladder cancer, you got BCG by your urologist, and that was kind of it. If you were a patient with muscle invasive bladder cancer, you pretty much were told you needed your bladder out. And once again, the urologist was involved, maybe the medical oncologist, and that was it. And if you had metastatic disease, the medical oncologist was involved. The radiation oncologist wasn't so involved 5 to 10 years ago. This is the new paradigm. And if this looks a little bit confusing to you, then I did the job right on the slide, because it is a little bit confusing. So for the whole point of this slide is to show you how bladder cancer has become multimodal. There is a medical oncologist routinely involved in treating non-muscle invasive bladder cancer patients with me. Many of you have been treated by a medical oncologist for non-muscle invasive bladder cancer. Muscle invasive bladder cancer, there's almost always a medical oncologist involved either before or after surgery if the patient's getting surgery. And if the patient's getting radiation and surgery, if we're able to do that, a radiation oncologist is involved. So this is where we are right now. And so that's going to inform this conversation. So what's the main problem that's been going on the last several years? So before the current shortage, and we're still sort of in the shortage, although it's improving, we had BCG shortages in 2012 and 2014. And at that point, there was actually two types of BCG being offered. There was Merck's BCG and there was Sanofi's BCG. The problem is that it doesn't just affect the marketplace for BCG. These curves show you that at the time of the shortages, be it in 2014 or 2012, the prices of alternative chemotherapies dramatically rose. Sometimes in the case of mitomycin, it rose more than fourfold where it's remained. In the case of valrubicin, it rose twofold. And my bias, I don't think that's coincidence. And so it just shows you that there are downstream effects of having these BCG shortages. Now then in 2016, after we had already had two shortages, Sanofi, one of the main suppliers, one of the two main suppliers of BCG, halted production due to issues with their manufacturing plant. And thus Merck's Tice BCG really became the only game in town. And that may not have necessarily been the direct cause of the current shortage, which we've been in for more than a year now, but certainly contributed to it. So all is not lost. This is going to be mostly an optimistic talk. We need a little bit of optimism in 2020. So I'll be talking to you about multiple different trials. These trials all have acronyms. They're sometimes catchy, Keynote, and that's probably the catchiest acronym. But the point is, I want you to look at when they started. They basically only started 5 years ago. And these are all major trials. One of them, Pembrolizumab, has already been FDA approved. And we expect that multiple others from this crop will be FDA approved. And so this is the current climate that we're in, which is really exciting. So let's specifically, I was tasked with talking not specifically about the BCG shortage, but about new solutions at this time. So what are ways in which we, as patients, as patient advocates, as physicians who treat primarily bladder cancer, what are ways in which we can address the shortage? And so one solution is to enhance BCG, increase BCG availability. And I'll talk about that and ways that we're working on that. Another solution is to enhance immunotherapy. And I'll discuss that as well. And the third solution is to enhance chemotherapy. This is an area in which I have intimate knowledge, and I'll talk a little bit about some of our own work here related to that. So let's first discuss the elephant in the room, which is BCG is, there are multiple different strains of it. It's common, and actually in many different countries, they use many different strains. So one of the questions that was written into us was about the Tokyo strain, which I'll talk about in more detail, and why we don't, and if that's available in the United States, and why we don't use that. You could easily ask about the Swedish strain, about the Prague strain, the China strain, you name it, you could ask about it. The issue is that every strain is viewed as a different drug by the FDA. So you can't just say all BCG is the same. It actually, that strain has to be evaluated in patients before we just adopt it. And there's reasons for that could be debated, and we can talk about that in the Q&A a little bit. but that's the idea behind SWOG 1602, which I know some of you have actually participated in. So the whole concept of SWOG 1602, there was multiple different reasons behind it. The PRIME trial evaluates patients who have never received BCG, who are newly diagnosed with non-muscle invasive bladder cancer. And actually, David is one of the leads on this nationally. So if there are further follow-up questions, they could probably be addressed to both of us, probably him in particular. But essentially what it does is it randomizes patients to one of three groups, to the tried and true TICE BCG, that's the one we currently use, or to the Tokyo strain of BCG, or, and this is particularly cool and interesting and novel, to an injection, an intradermal injection, this is here, of the Tokyo strain, followed by a bladder installation. And the reason for that is this whole concept that you can prime the immune system. You can sort of get it ready so that when you actually give the drug in the bladder, it hones all of those tumor-fighting agents, all of those tumor-fighting antibodies to that bladder cancer. It's prepared. So that's the whole idea of the prime arm. And this has been enrolling, I think, several hundred patients. Dr. McConkey may weigh in. I'm not sure the exact enrollment, but is an option we have open at Hopkins. And the whole idea is, once again, as I just said, to increase BCG availability, in addition to test out this hypothesis about priming, revving up the immune system before you give BCG. Okay, let's keep moving on. And if you have thoughts in your head about any of this, it's ripe for discussion afterwards, and happy to talk about specifics. So let's talk about number 2, which is to enhance immunotherapy. So BCG is a form of immunotherapy. So there is a class of drugs that have been widely used across multiple cancers. They're called checkpoint inhibitors. You may or may not have heard of them. And the one that has been FDA approved earlier this year was called Pembrolizumab. Okay, and I'm going to try to explain to you sort of how these checkpoint inhibitors work, because I think they're pretty interesting. This is going to go back to sort of science class. This is immunology. So when a tumor is in the body, a antibody actually recognizes it, okay, and sends these CD4, these T cells, to go replicate and expand, okay, and they replicate and expand into these cytotoxic T cells, okay, which kill the tumor, X out this tumor, okay. But the body and the tumor has figured out a way to hijack an important component of the body. And the way that it's hijacked this important component of the body is basically by utilizing the body's own resources to trick the CD8 cells, these CD8 cells, into sort of not recognizing the tumor, okay, through this mechanism called the PD-L1 checkpoint. And so when the tumor sort of utilizes the body's own mechanism to silence these T cells that kill the tumor, okay, it evades the whole architecture of getting the immune system to fight the cancer. And so PD-L1 blocking agents work right here and essentially say, no, we are going to block this so that the cytotoxic T cells, these cancer-fighting T cells, will actually be able to fight the cancer, and the tumor won't be able to hijack the system. So that's the whole idea of pembrolizumab. So, you know, I'm not going to go over the trial literature too much. We can talk about that in the Q&A, but I'll just give you sort of my pros and cons about utilizing it. So it was FDA approved for BCG unresponsive bladder cancer. So patients who have had BCG and have recurred within a certain time course. And the pros in my mind are that, and let's just start with this middle one, which is a pro and a con, depending on your view. So if you look at the data, about 20 to 25% of patients did not have a recurrence after out to 1 year. That means within a year, the vast majority of patients on this drug had a recurrence. And patients need to understand that, okay? So that's a pro and a con. If you're in that quarter of patients that have a durable response, you're happy, but there's a lot of patients who are not gonna have a durable response. But it does potentially avoid, a cystectomy, or, you know, perhaps it kicks the can down the road. That's a potential pro. And there's low progression on the trial to muscle invasive bladder cancer. The cons are there are side effects. We can talk about those more in detail. There are autoimmune side effects. We don't truly understand the long-term efficacy. And it's unclear yet whether, a patient who may want this drug, if their cancer progresses, whether this drug, which is widely used for advanced bladder cancer, whether it will work as well if you've already sort of seen it in early stage disease. I don't think we know the answer to that yet. But let's keep kind of moving. I'm going to talk about two other really exciting drugs that are very likely to be FDA approved. I'm not going to spend too much time, and they're both related to the immune system. And I'm not going to get too much into how these drugs work. We can sort of talk about that in the Q&A if it very much interests you. But one is, both really are meant to rev the immune system. Adstilladrin was actually is a novel gene therapy that was actually discovered at MD Anderson, and Dr. McConkie was very involved in that work. And it's really a kind of an amazing story of true bench to bedside. So something that was created in the laboratory and made its way to the patient. And this is before the FDA currently. And it is an intravesical lead through a catheter delivered gene therapy that will be available, hopefully, if it's approved. I'm hoping within the next 6 months would be amazing if that could happen if it was approved. But it's for also, once again, BCG unresponsive bladder cancer patients. And we can talk about specifics with any of these drugs related to, well, like how well did it work on the trials and in what patients did it work? That I think that's better for the Q&A, because I do want to leave some really good time for that. Another drug is called Vicinium. So it both has a direct cytotoxicity, so it kills cancer cells directly, but it also revs up and activates the immune system. This also is either before the FDA or getting ready to be. Its major phase 3 trial, which was called the VISTA trial, is already done. And I think many of us also anticipate this may be FDA approved. So we'll see though. So we went from having really no FDA approved alternatives to BCG after, recurrence after BCG, to now we have Pembrolizumab, potentially Adstilladrin if it gets approved, and potentially Vicinium if it gets approved. And by the way, the trials aren't even done yet for newer drugs. So the world is vastly changing. So solution number 3 is improve intravesical chemotherapy. So let's just talk for a second about intravesical chemotherapy. So it is the old sort of tried and true alternative to BCG. Valrubicin is FDA approved, but Most of us do not use valrubicin routinely anymore because we don't believe it has the same efficacy as what we currently use, which is combination gemcitabine and docetaxel. It's really been used since the early 80s, intravesical chemotherapy, but only recently have we started using combination therapy. And I'll talk a little bit about advances in combination therapy in the next few slides. So what's the problem with chemotherapy delivered intravesically? It's actually not that it gets systemically absorbed and that your hair falls out, although there have been isolated cases of that, or that you get systemic toxicity. It's the opposite problem. It's that the bladder is a hostile environment. And when you give a drug, you immediately urinate it out, basically. So this is a now very dated study, but I just really liked it because it's so simple. They gave a Taxol, a type of chemotherapy, into mice, and then tried to wanted to recover the dose of that chemotherapy in the urine versus the tissue. And what they found is they recovered about 90 to 93% in the urine, and basically only recovered 1% of the chemotherapy in the tissue. So this is a problem, obviously. So in the last 5 years, there have been massive changes to how intravesical chemotherapy is delivered, and through the field is called drug delivery. So compared to standard chemotherapy, there have been different approaches. For example, heating the chemotherapy up, that's called hyperthermic chemotherapy. Mechanical delivery, we had a clinical trial with a ring, kind of like for those of you that know what a Nuva ring is, estrogen for birth control. It was very similar, except delivered into the bladder, and it slowly released chemotherapy over time. And that's in development. Hydrogels. This are a class of drugs that we also had a clinical trial open. For those of you that may have heard of the Mitagel trial or the Urogen trial. These are aqueous or water at solution, and when it enters into the bladder in that warm body temperature environment, it forms sort of a pseudo solid, like a gel, and then it slowly releases the chemo over time. And then lastly, nanoparticle approaches. We currently have a trial that will probably be closing soon, looking at NanoDOCE, the docetaxel chemotherapy that's nanoparticle bound. So these are all ways in which we're trying to address the delivery sort of failures of traditional chemotherapy. Although, as I'll show you, there's also other ways to address those issues. So my lab also looked at in concert with Laura Ensign and Justin Haynes, who are these two brilliant nanomedicine engineers at Hopkins. One of the sort of benefits of being at a place like Hopkins is the amazing, incredible talent of collaborators. So essentially, we derived a nano cisplatin. And when it was, I'll just explain these bar graphs, but when it was delivered into mouse bladders, the particle we constructed was still had real drug levels in the bladder 4 hours later in the actual bladder tissue, whereas traditional cisplatin, which is right here, had none. So this was really encouraging. And this kind of shows this pink shows 4 hours later the actual drug still being in the bladder. But what was most encouraging is traditional cisplatin actually does leach into the bloodstream, but in the nano platinum that we derived, it did not. So we're pursuing this and very enthusiastic about this approach. Let's talk about the other problem with chemotherapy that we're addressing, and this is the whole concept of multi-agent chemotherapy. And so my mentor, who is a guy named Jim McKiernan at Columbia, told me, and this was about 10 years ago, and really got me interested in this subfield of bladder cancer, that medical oncology figured out years ago that single agent chemotherapy doesn't work well, and yet urologists still stick to single agent therapy. And so we did not invent the combination of gemcitabine and docetaxel, which we call GEMDOCE, but we were one of the, I would say, early adopters. The urologist who is kind of attributed with sort of first starting it is at the University of Iowa. And Dr. Schoenberg, for those of you who were his patients, and Dr. Bevilacqua were very early adopters. And of course, I was enthusiastic when I came onto the team as well. And the reason is that when you put it head to head against some of the other drugs that I just talked about and that we had done in trials that are actually have more toxicity than GEMDOCE, I think it competes really well. So when you look at high grade recurrence-free survival at 1 year, it's 53%, and at 2 years, 35%. This is retrospective, so it's not a clinical trial, but it's our experience. And maintenance therapy really matters. So when patients are getting maintenance therapy, that 2 year recurrence-free survival goes above 50%. And that's why we, enthusiastically support maintenance for this regimen. So we had a very interesting series that we combined with Iowa and some other major centers that during the BCG shortage, we actually had no alternatives in some cases other than to give GEMDOCE. So then we combined that data with many other centers and said, how did GEMDOCE do for the newly diagnosed, not the BCG unresponsive, but those patients who actually had never seen in BCG. And what we found is that recurrence-free survival at 1 year was 76%, and recurrence-free survival at 2 years was 66%. And so based on this, I wrote a trial that we've begun enrolling, and this is a single arm trial to really push the envelope and say this regimen may be better than BCG. We're enrolling a total of 26 patients only at Hopkins, and we're giving them this regimen for newly diagnosed patients who have not yet had BCG. Why are we doing that? Because I do believe that it may be a very promising alternative to BCG, particularly in times of shortage, but maybe even not. And ultimately, the goal, if we can prove that this is a safe regimen and that the efficacy can compete in this initial trial, the goal will be to have a randomized controlled trial. We'll probably need to recruit over 1,000 patients throughout the United States for this. But stay tuned, because I think this is sort of where things are going. So just to sort of recap how I think about BC, as somebody who treats a lot of these patients, a lot of yourselves, how do I think about the BCG shortage? I think of new solutions, and new solutions can be a couple different routes: increasing BCG availability, enhancing immunotherapy, and enhancing chemotherapy. So thank you. I want to thank the whole lab. I want to thank Dr. McConkey for inviting me. And most importantly, I want to thank all of you patients, and equally those patient advocates who are so essential to the care of our patients and help making really important decisions. And I will now stop my screen share.
Thanks, Max. So we can open this up for discussion now. If you would please type your questions in the chat. We will go ahead and kind of handle them in an organized fashion. So I know, Max, that you were pre-prepared with some questions. Should we start with those?
Yes, I was. Let me pull them up. So I addressed some of these, but certainly not all of them. Yeah, one of these is specific. So I purposely did not want to be specific to the trials currently available at Hopkins, but I, of course, can discuss it. So as a general rule, our approach is to try to have a clinical trial available to a patient at every disease, at every sort of decision point in a patient's bladder cancer journey. So what do I mean by that? So I mean by that is, ideally, we would like to have a clinical trial open for patients newly diagnosed, for when they recur after BCG, for when they recur after that, for if they're having a surgery, before surgery, a clinical trial, after surgery. So that's what I mean. I think that we've largely been successful at that. I don't want to delve into too much of the trials we have open at any given time, because it is definitely constantly shifting. We meet twice a week. We meet with the whole cancer center once a week, and we meet with the bladder cancer clinical trials group once a week. And we're constantly talking about how many slots we have on a trial before it closes and what trial we're opening. So, but I will say that, you know, we also try to have trials at different phases. So those of you who don't know what phases of trials are, a phase 1 trial is really looking at toxicity, but it's less proven. A phase 3 trial, a phase 2 trial is looking at sort of an initial efficacy with some toxicity. A phase 3 trial is really for FDA registration. So it's going to be large and randomized. And we try to sort of cover, and there's reasons to have multiple different types of those trials open.
Thanks, Max. So maybe we can get back to this discussion you were having about the different kinds of BCG that are being tested in the PRIME trial. So what's the difference between them in your mind?
So, you know, there is some data from the lab that suggests that the Tokyo strain, how do I say this, may have more potency than the traditional Merck strain we have available in the US. So when I counsel patients about this trial, I say there's some okay data to suggest that it may help you to be in the Tokyo group. There's no data to suggest it will hurt you. So I sort of present the trial as, in my opinion, and everybody has what they bring to the table, it's sort of a might help, shouldn't hurt type of trial. Meaning, I don't think there's any data to suggest the Tokyo strain is worse than the Merck strain. Although, you know, obviously that's why we're doing the trial. It could be, we won't know. But there is some data from the lab, and I know, you know, you have a lot of familiarity with this, that shows that it could be more potent.
Thank you. So there's a question coming in from somebody who's already in the GEMDOCE maintenance program. He says the major problem is keeping the treatment in my bladder. After 15 minutes, the urge to release the GEMDOCE becomes unbearable, and the pressure is released along with some of the medication. What can be done to help the patient keep the GEMDOCE in the bladder for at least an hour?
Oh yeah, that's a great question. So first of all, I'm not 100% that keeping the GEMDOCE in the bladder for an hour matters. We don't know. What do I mean by that is, I believe that there is a immune response to the chemotherapy. We traditionally think about giving a chemotherapy in the bladder, and it's supposed to kill the cancer cells. But I think that what's also going on is that there's also an immunologic recruitment of these cancer-fighting immune cells to the bladder. And so it's not clear to me whether even just keeping it for 15 minutes might be good enough. But having said that, you know, so I tell patients that. But also, you know, we do know that maintenance on GEMDOCE for some patients, as they get more and more of these doses, and this is true of any chemotherapy, it's really true of BCG too, bladders can just become more irritative. And there's different drugs we can try to give to relax the bladder. But ultimately, you know, some patients may not be able to complete a full, you know, 2 years, and that's okay.
Thanks. So do you find that different patients have different problems with GEMDOCE, or is this pretty typical that people have trouble keeping it in for now?
No, I mean, I would say it's not typical, but it happens. And it's very similar to how some patients react to BCG, which is some patients get a sort of an irritated bladder from it. And a lot of us will be pretty aggressive and we'll sort of try to push them through it with medications to relax the bladder with the BCG. But at some point, some patients have bladders they aren't built for it. They don't tolerate for whatever reason that drug.
Excellent. So another question is the Tokyo strain currently available for patients? And I guess a corollary to that is, do you think it will solve the problem with BCG supply?
It's not that first question is easy. No, it's only available on the trial, and you have a 2 out of 3 shot of getting the Tokyo strain if you do go on the trial. Do I think it will solve it? No. Realistically, I don't think it will solve it, but I think it will certainly help it. I am a little bit concerned about sort of the supply of BCG long term. I think we all are, but I think this will help.
Great. So the next question is kind of related to a question we had asked of us at Beacon at the think tank, which is, what are the current alternative go-to therapies? Or maybe we can ask, what are the therapies that are available for BCG unresponsive disease? What's your favorite one and why?
Yeah, so in September of 2020, my answer will be, for the most part, GEMDOCE is what I pull to out of the cupboard and counsel patients about, mostly because I do think that the systemic immune checkpoint inhibitors can be successful in certain patients, and they are FDA approved, but there is more toxicity than with GEMDOCE. In December of 2020, what will I answer? That will be a little bit harder. So if Vicinium and Adstilladrin are approved, I have much more familiarity with Adstilladrin based on the Hopkins involvement in the clinical trials. Don't have as much experience with Vicinium, so we'll need to tread a little bit more gingerly with that. But I'm enthusiastic about the broader paradigm, which is, as we develop more and more therapies that show that there's not much progression to muscle invasive disease, we may be able to just delay progression to the point of it never happening. So that's sort of the exciting thing about all of these drugs coming into play.
I agree. And I guess a couple of comments about Adstilladrin. So the paper describing the phase 3 clinical trial results has been accepted for publication at Lancet Oncology. The response rates were consistent with what were observed in the phase 2 clinical trial. And as Max said, the data are being reviewed by the FDA right now. We wouldn't be surprised if we see an approval coming soon. That trial was done in BCG unresponsive disease. The company is moving forward with Adstilladrin in BCG naive disease, and the trial will be led by Trinity Bivalacqua here at Hopkins. It's called ABLE32, and that trial is not a head-to-head comparison with BCG, but will provide us with information about how well the drug works in that same disease state. So then Max has shown you the data with GEMDOCE. We have BCG, maybe 2 forms. I should mention the PRIME data with the Tokyo strain for patients with carcinoma in situ is already under review at the FDA. We expect that trial to finish accruing sometime around December of this year. It's a over 800 patient trial. I think the target enrollment was 962. So I think the Tokyo strain will be under review, might even be approved soon. So to answer this question, I think there are going to be several go-to therapies. including a different form of BCG a year from now, as Max was saying, that'll complicate matters to urologists to decide which one is best for a particular patient. That's where Max's work with biomarker development comes in, to try to discover strategies to tell who's going to be benefiting the most from GEMDOCE versus who's going to be benefiting the most from BCG. Hopefully they're not benefiting the same patients, and there will be a way of expanding efficacy to more patients this way. So can you tell us a little more about Vicinium? What exactly is that drug? And is it available too?
Yeah, so Vicinium is not available. They had a trial called the Vista trial that has completed. So I don't know if it's before the FDA or about to be. It's slightly different. So it is directly cytotoxic, also sort of generates an immune response. And it's sort of it kind of uses the architecture of a bacteria or virus to get into the tumor cells and kill the tumor cells directly, and then sort of recruit an immune response. That's sort of the best way I can sort of describe it without getting into the nitty-gritty. It's a little different in that it's given a little more often than, for example, Adstilladrin. So it's I believe it's actually given upwards of, I think, a total in the trial, I think it was 20 times within the first year. I'd have to look at that data again to be sure of that. Whereas Adstilladrin is one of the nice things about it is it's actually less frequent. So there's going to be some pros and cons. I think it's a little bit too soon to we have to have them FDA approved first, but you're right. It will be very interesting to see sort of where we do in terms of order. We have a question in the Q&A. Chemotherapy is notorious in the patient community for side effects, nausea, hair loss, and chemo brain. Does GEMDOCE involve similar side effects? So I used to answer this unequivocally no, but then actually I had a patient who got one dose of actually gemcitabine intravesically and had her hair fall out. So I will almost never say never anymore. But I will say that out of treating hundreds of patients, I've seen it once. So systemic side effects of intravesical chemotherapy are incredibly rare, and even in her, it was non-toxic, meaning she had some systemic side effects, but her blood counts didn't change, things like that.
To me, I can ask you a question, Max. Why aren't we using radiation in non-muscle invasive disease? And second, I guess, question would be, can you tell us a little bit about Noah Han's ADAPT bladder trial?
Sure. So I think we have a few patients who are actually listening in who have been on it. Noah Han, who those of you who don't know is a medical oncologist on our team, designed a really brilliant trial giving a drug called durvalumab, which is another one of these checkpoint inhibitors, these sort of sexy new drugs, with either, in some cases, BCG, and in other cases, radiation. It's pretty exciting because it's the first trial to look at radiation for this group of patients. And we'll just have to see. Data has not been presented. Although the trial is still open at Hopkins, one of the really unique things about the trial is the arms are changing. So as certain combinations with durvalumab end, others are beginning. So for example, I think the ADAPT trial, and that's why it's kind of called ADAPT. It's very cool. So I think in a couple of months, we're going to have GEMDOCE be combined with durvalumab in that trial. So stay tuned. Back to your question about radiation. I think radiation has its place for different types of bladder cancer, but like I tell most of my patients, no good deed goes unpunished. So there are, there are side effects to radiation, and there are long-term and short-term side effects. And it's a balance of what we think we can get out of the cancer efficacy with what we're able to stomach with those side effects. And so I think that's probably the reason radiation isn't widely used in earlier stage disease. But I think that there are select cases in which it has a role.
So I'm going to stop hogging the questions and answers for just a moment. If someone has a question, you can go ahead and type it in the Q&A. I'll ask Max another one if there's no question coming soon. Okay, so Max, on Friday, we actually had the opportunity to do a Zoom meeting with some of our friends up in New York City, including Jim McKiernan, your former mentor, and Eugene Pietzak was discussing what he thinks happens to muscle-invasive bladder cancers that evolve from non-muscle invasive cancers in patients. He thinks that they become more aggressive stage for stage than cancers that arise as muscle-invasive cancers at clinical presentation, at first-time diagnosis. What do you think about that? Does that make sense with what you've experienced? And
yeah, I mean, I think that the way to think about it is stage is not always directly representative of how aggressive bladder cancer is. So what I mean by that is somebody with a newly diagnosed muscle invasive bladder cancer that subsequently is removed. I'm not sure that cancer can be considered, less aggressive than a non-muscle invasive cancer that has had every opportunity not to come back. So it's been removed, and then it progresses to muscle invasive cancer. I think that tells us something about the biology of that cancer, that it's going to be resistant to to multiple different types of therapies, and that it has mechanisms, it has machinery to escape our best efforts to kill it. So that's the way I think about it. Is I'm not so sure about the muscle invasive ones. There's probably less aggressive and more aggressive, versions of those. But I do think that the ones that sort of escape all of our efforts and then become muscle invasive are, I agree, are ones that need to be taken particularly seriously.
yeah, he was actually suggesting that, as the cancers dodge BCG, they evolve in ways that helps them also dodge other ways we have of killing them later, like immunotherapy, checkpoint inhibitors like Pembrolizumab, and also cisplatin-based chemotherapy. So I think as a research community, we're going to have to watch that, see if we can confirm those results. And then the question would be, are there vulnerabilities in those cancers as they evolve away from being sensitive to the immunotherapies and the chemotherapy that we have? Are there vulnerabilities that we can identify that can be then used to treat those cancers later? So I don't see any new questions in the chat. Let's give people one last opportunity to ask any questions. Seeing none, Max, I want to thank you very much for giving us this fantastic presentation. And thank you all for joining us today. I want to again encourage you to consider joining us for the virtual Beacon Walk on October 3rd. And thanks to our staff for hosting this meeting. I hope you all stay safe, and that we'll see you again next month, where the next presentation will be from Jeannie Hoffman Census. So take care, everyone, and we'll see you soon.